non-medical staff to see this later and learn from you. So thanks for joining us.
No, thank you, Azim, for having me. This is definitely a great pleasure and honor. And of course, it's good that we can connect through Monty Hart Grand Rounds. And the idea was brilliant, and you connected really all the interventional community together. Team approach to Cath Lab's complications. I want to go with you through some slides. Definitely what we know, the human error, because complications, beyond the complications, generally there is a human error. EAL 401, okay, that's not a randomized study, it's actually a flight number of a unfortunate flight, 1972, 99 deaths. Big disaster in the 70s. It was really the time of the big airplane crashes. What happens? I show you this because I want to illustrate you quite impressively what a human error means. This airplane actually crashed because nobody flew it. The autopilot was switched off from altitude hold to control wheel steering. The captain, by mistake, leaned against the yoke, so entered a gradual descent. Then the crew was distracted because there was some defect somewhere. A light wasn't working. The flight engineer had a cup of coffee somewhere. And at the end, so nobody was there, and the plane crashed definitely, and with nearly 100 deaths. Even worse, 5 years later, that was the biggest ever aviation disaster, nearly 600 deaths. What had happened here? Again, the pilot, which was a very professional, seasoned pilot, he was a little hasty to take off. He thought there was the takeoff clearance, but he did a mistake. So he went off. He didn't speak Spanish, so maybe there was some warning. We don't know. And there was another plane on the takeway, and 600 deaths. Since then, at least as a corrective action, English was introduced of official language for all airports, which is definitely important. 1 year later, a little less deaths, but still a tragedy, as you can imagine. Again, so stupid. It was a light problem because the light for the nose gear for landing didn't become green, and that was necessary for the airplane to land. Red. The captain said, "Oh, we cannot land." Even though the first officer and the flight engineer were there, no, you cannot circle around the airport. We are running low on fuel, but he ignored the warnings, and the plane crashed without fuel. And at the end, at the analysis, finally, after 10 days, the bulb had simply burned out. The light wasn't working. There was no kerosene left, and also, I think very importantly, the captain didn't listen to the members of crew that there's a problem. We don't have any fuel anymore. So in all of these three cases, very impressive cases, the crews, the teams was technically competent, but the system and the procedures didn't catch these fatal mistakes. In short, the system did not work, and this brought to these tragedies, and all of these can be brought back to human error. Let's come back to us. Afterwards, I explain you why I took this high road to get to us in the Cath Lab. Why a perforation here? You can see it's a small, okay, maybe not a tragedy, but of course it's human error. It's not error of the wire or you have chosen the wrong wire, or you just perforated the coronary. So again, we have most of our complications. There is human error before. Here again, perforation, is it inevitable? Calcified or fibrotic? Is it bad luck? No, it's human error, because maybe the balloon was too big, maybe there was too much air in the balloon, maybe you didn't prepare the lesion with a rota, which maybe have avoided this. But you can also, there's always a weak point where we do a choice which isn't the right one, which brings us to the complication. Here it's a fatal complication, very bad, and unfortunately here the flight number, that's my name, 2004. During carotid artery stenting, you see here a small embolization, very small branches, but the patient highly symptomatic, neurologically, together with the neurologist who came. No, let's try to open this up. Of course, now we know it's much too distal to intervene. You wait and see, and it will get better. Anyhow, here you can see this dissection during wrong wire, wrong adjustment material, and it was via perforation and with a fatal complication of intracranial bleeding. So of course everybody has this kind of skeletons in our cupboards. And as I said before, all these complications we can go back to human error. So sorry. What can we do? Let's go back again to aviation, because aviation did after the 70s, or at the end of the 70s, after all these terrible disasters, the crew resource management. So the National Transportation Security Board recommended to start a program in 1978. And interestingly, it was written by a psychologist, Alan Deal. Then it was called the Crew Resource Management. Another psychologist from the NASA coined this name in '79. The United Airlines was the first airline which started the Crew Resource Management program in '81, and by now, in the 1990s, became global standard. And since then, since 30 years, it's a global standard for aviation, to train aviation to avoid or manage complication or disasters. Okay, it was written by psychologists. They look into human nature, and maybe this is something which we should look at also, because we are also humans in the Cath Lab. And it's based on two fundamentals and incontrovertible realities. First, as I showed you with this beginning terrific images, human beings are fallible and will inevitably make mistakes. But the other fundamental is, let's say, more positive. Human beings are individuals with a rich diversity of personalities, cultural backgrounds, talents, and skills. What brings us this to? So we make mistakes, but we are also very different, and different talents, possibilities. So we are by nature, or also by nurture, by training, being individuals. Some are better to talk, some perform better under stress, some have more experience because they're elder, or they joined in a short time a lot of experience. Some have better skills, better hands, two right hands, we know this. And maybe all this mixing together gets us to try to do the management of complications of disaster as a team and not as an individual. Because if we want to optimize our performance and increase safety, which is very important, we have to recognize that we make errors. There may be some reluctance to report this error. So it's very important also to tell always the truth, what happened, but I'll come back to this. And that complex, high-risk endeavors, teams may be more effective than working as an operative unit than a single individual, than just one person. And we know that in a complication, a single operator does nothing. A team may be able to solve the operation and save the patient's life. So what this CRM wants to do is to cultivate, train these team-based tools to reduce the adverse impacts of our errors that we do. Quite important, it promotes a non-punitive culture. So you don't want, oh, you made an error, now do EP or go on the ward. Okay, maybe a week or two, but try not to be non-punitive, because we want the team to go ahead and work, do some more procedures, definitely. We want to get some comprehensive and clear operating procedures, and focusing on self-convincing and hands-on systems to improve the team performance. Okay, hands-on systems for the aviation, you know, all these video trainers. In our Cath lab, okay, so we can talk. We also have some possibility to do it out the Cath lab, but actually complications just happen quite oftenly. So if there is one, of course, as a team, we need to perform and we need to stay together to go to it. Let's go practically. Here we have seen that all, the iliac artery rupture. Here you see the big bore sheet. There was vasospasm. The patient had long steroid treatment, and actually retrieving the sheet was nearly disrupted the iliac artery from the aorta here by retrieving the sheet, definitely with a little bit too much force. Here you can see the huge rupture. What have we to do now following the roles of CRM? Okay, we had the human error. The sheath was retrieved despite the vasospasm. We have to impart leadership. So somebody in the Cath lab needs to be the leader and give the several orders to the people in the room. It's better that's just one person to avoid that there is too much or a too complex situation and nobody speaks over the other one. In this very case, in this complication, we had two operators, two nurses, and the anesthetist who was already there. Of course, you may have to call adjunctive crew. In this case, another doctor definitely can be helpful here. Vascular surgeon, it's a vascular problem. If you have one, you need. Then you have to communicate to explain clearly the situation. Again, that needs not to be the leader, because a leader may be there to get another access. It may well be the second operator who can clearly explain the situation to the people who were coming in the Cath lab to the situation. So what do you have to do at the table? Okay, somebody had to definitely press the groin in this complication. Somebody has to get the contralateral access, which may be the first operator. Position the covered stents. The circulating nurses have to get the material, drugs, ask for blood. At the patient head chest, definitely here, you have to intubate a patient like this. Cardiac massage needs to get started. Then the team leader again promotes preserving his austerity, anyhow, the chain of command, but has also to have an open ear for any possible suggestions, as we have heard before. In the other case of the air crash, okay, we are running out of fuel. The pilot didn't listen to them. Now we have to listen to them. And if somebody comes here, put an aortic occlusion, if it doesn't cross our mind as first operator, of course, it's the best idea to do. We have to go do it. And then, of course, finally, we have to debrief after this complication. Here, okay, covered stents were positioned after the aortic occlusion balloon, which was positioned from the other groin. And then we have also the corrective actions. Again, we have to thank Antonio Colombo here. We did a contralateral protection now with this wire or 18 wire. And well, there are other now protection, but we know now we have to protect the groin where we puncture with a large burr, because we want to avoid this kind of complications. The team approach. Of course, everybody knows, not only chief of cath labs, but also during sports, it needs a lot of effort and time to build a team so that you can approach this complication as a team. So how can we prepare our team for complications? Okay, first of all, we have to train, which is actually the start of a complication, communication. So we have to learn to talk what is essential clinical facts. And we can ask it as chiefs, Azim, as you do, as Antonio did, and all the cath lab chiefs during ward rounds. Don't tell me the past medical history of the last 30 years. Give me 3 exact things and I know what is happening, what's the patient about. Case presentation, we can learn it. Cases in the lab. Okay, give me a short sum up of what happened, what have you done so far. It's a little bit like share information, share your position with Google Maps. I think to me it gives a little bit the idea. So Azim takes, oh, here is a cath lab, but the anesthetist on the other side of the town, and through Google Maps we meet with all the information in the cath lab, so we have the information together, and we can, after this good communication of the problem, go there and face our complication. What do we need else to build the complication team? I think what is very important, and we learned it from Antonio, Azim, you know, so you discuss during every case, even during a type A, right, coronary single stent procedure. What do you think? So you have to talk. So you get a little bit the same idea of what you're doing. You want to do it in the same manner, and then as a team, or next time also as an individual, the right coronarity is treated in the same. And include the colleagues. So what would you do? What won't you do? So I think if you want to work together, you have to discuss, especially if you don't want to work in parallel, but you want to work together. And then every patient coming to the cath lab is a patient of a team. I think this we have to understand. Even it's a homeless or VIP, every patient somehow enters the cath lab, but now is responsibility of everybody, because somebody sees, oh, there is an open introducer is bleeding to the floor. You can see it only from outside, but it's a patient of the cath lab. Somebody has to tell it if he sees it. And of course, if there is a complication, this is even more true, because then everybody has to be part of the complication and try to get the patient out of the complication. Include all present doctors and nurses, but maybe also the not present, into the complication. Of course, you don't want to have too much entropy in your cath lab, but if somebody watches from outside, they are welcome. They will see, they will learn, and they'll be useful. When we are out, there's a complication. They have learned and they can treat us better. And of course, the people who are needed, you call in the cath lab. If there is too many, then of course the team leader sends them also out of the way. But it's hardly ever there are too many people in the cath lab, I would say, during a complication. What else we have to do? Again, you're not involved yet. A colleague comes by and sees, and he has to offer his help. I think if you go into cath lab and there is a complication and you see some people from the team outside and they just watch, but they don't offer help, so they are outside the team, you understand this immediately, but they need to become part of the complication team. Maybe they have an idea, maybe they may help, and if you think, no, we are quite fine, okay, then they go away. But it cannot be that there is a complication and somebody calls themselves out of this business. You need to be. Well, non-punitive, I said already. Complications meeting definitely are definitely useful, nearly as useful as to have a pizza together, of course. This is also important for the team. Okay, there are barriers, there are problems to do a team, and we have also to look at this: conflict, lack of coordination, fatigue, lack of role clarity, inconsistency in team membership. So how many are there, fluctuant members or doctors, visiting doctors who they are there once a week in the Cath Lab. But anyhow, you have to feel them that they are a team the same, because if a visiting doctor has a complication, of course, the team, the Cath Lab, the present Cath Lab team, the resident Cath Lab team, has to manage this complication, not only the visiting doctor. Conflict in the team, there is competition between doctors, we know this, but they are absolutely forbidden. Conflict is absolutely forbidden during complications. We spoke an oath of Hippocrates, so we have to save the patient, and we are professionals, so I think this should be clear, cannot be there. Afterwards you can fight, but not during. Lack of coordination, again, we have to work together, and I always liked, one doctor, one nurse at the table. I never liked for a PCI. It's two doctors, because you learn, you work together, and you teach, you learn, and you can talk. Speak while you're doing your procedures. Fatigue and workload, okay. If you think they are tired, and like now in this period, this summer, all people didn't have holidays for 1 year due to COVID, and now it's so important that everybody goes at least 2 weeks on holidays. Now it's very important that you go there and you are a little bit not too tired to work, because if you're tired, more complications happen, and less bright you are to get out of complications if you're tired, of course. So who is in charge to build the team? The chief of Cath Lab, Antonio Colombo, Azim, myself also now. What we have to do? Well, okay, you have to teach, integrate all staff, doctors and nurses, talk, organize meetings. You have to trust your co-workers, because sometimes you're away, but you have to trust, how they work, and if not, if you don't trust them, you have to train them better. You have to recognize individual talents. Okay, he's so good at talking. No, he's really good as a team leader of a complication. Actually, not as good with the wire work, but complication, he's a man. And I always remember a fellow I had in Milano, Luca Favro. He still was learning his handwork, but he was so good at complication. So I really liked him, because I could really concentrate on the handwork, and he organized all the rest. So that was his talent. To build a team, chief of Cath Lab, he has to defend and take care of your team. Of course, you can give him a hard time if you're there, but then from the outside, from administration and from other people, they need to know that you are working with and for them. Relationship with anesthetists, with vascular cardiac surgeon, it depends a little bit on the chief of Cath Lab, because if they come there and they're happy, oh, look, they have a complication, I told them we have to do open. No, you have to speak together. They are sometimes in mischief, we are in mischief, so relationship is important. And okay, the positive work environment, somewhere in between of dictatorship and comfort zone. I don't know, Azim, now will hate me. You're, I think, as long as Damiano, Antonio, Mangieri tell me, you are quite tough. Antonio in the middle, I'm very much in the comfort zone. Of course, you need in between to have your kind of how you run a Cath Lab, and everybody has his own moods. But at the end, you have to build a team and defend and take care of it. you have responsibility. But not only the chief of Cath Lab is in charge to build a team. Senior staff, they have to teach. They form the fellows for the team. And senior staff, you have to be aware. Once you will be the chief, and you have to build up a team. And if you work for 5-6 years in a Cath Lab, or you build it up, and then you get a dream team. It's such a good time to work during these years for a team. It's really these 5 years of work that go so easy. Okay, then maybe the team falls apart because they get grown up and they go somewhere else. Okay, then you start from scratch and you build another team. But it's really nice. It's like a little bit the trainer of the football or baseball teams. Okay, you build up, and okay, then you have success, and then okay, maybe you have to change. But I think it's good. Also, the fellows in the team, you have to go together, and if you want to manage the workload to get it done, and if you really want to grow, the only way is to do it together. If you fight, no, that's my case, it's my case, or that's my patient, that's the other patient, you will go nowhere. And of course, you get a drink together, which is also very important. Of course, here now, I think here we are mostly doctors listening, but the Cath Lab staff, everybody is very important. Nurses, as much important as doctors. And there are nurses where you, with blind eyes, you go through a complication. Okay, you have to teach them, and they have to learn. They have to prepare their procedures. They have to do the checklist, whether their FIP is working. They have to build their team also, participate in the meetings. The wrap-ups, we have to go together, what happened. Sometimes the human error comes also from them. Mostly they see when we do something wrong, but so they are definitely very important part of the team. One other message, and maybe it's even more true in the team or in the Cath Lab team than at home with your wife, but I haven't said that. A team can work only if everybody really tells the truth. As we heard before, during this aviation disasters, somebody's reluctant to admit the errors or mistakes, but you have to admit it immediately. Oh, I forgot to give heparin when you see a thrombosis, or the patient didn't do that. Oh, maybe there was some air. It needs to come out immediately, because then we can start to face the complication in a complete different way. Maybe I went out with a wire, so never hide anything. You also have to give some advice. No, patient did fine. And you forgot to tell, no, there was a rigid peritoneal, there was a tamponade. So never give the truth what's happened, and then we can face every problems. I think also if the team has to understand what is the objective of the Cath Lab, it's quite important. Is this a number of procedures? Is this a number of studies? Is this new devices? If you want to go successfully or get to your objectives as a Cath Lab chief or as a team together, you need to know where you're striving for, which are your objectives, and you have to talk about. And maybe also sometimes money, safety. So if somebody thinks, no, he's working only for himself, his own interest, it's difficult to have or convince a team to work for him. So I think you may share this objective. And then you have to admit when you're tired, or somebody sees that you're tired, admit, sorry, can you take over? I'm really tired with this procedure. And if you're really team, one does the CTO, the other does the stenting. I think that's perfect teamwork, because it took you 3 hours to get a wire through. Let the rotor blader do somebody else. You have done a lot. And if you're a team, patient will be fine afterwards, because you trust the colleague who will take over. So the last bridge to the true resource management. So we focus on the member attitudes and behaviors that affect safety. We adopt the team rather than the individual to our training unit. So we train as a team and not you get better, you get better. No, we want to train it as a team. Active training, well, it's to do complications, but here again, Azim, Antonio, and me, we are quite able to find or prepare complications for our teams, or have been, but this is the way it goes. We impart leadership and the teamwork skills, of course. Team member input, it's very, very important during the complication, but also afterwards. What would have you done better? And so I think it's very important. And of course, the debriefing is very important. We have a checklist from this team staff courses. You find on internet also. So how we did our approach to the complication. Was it good? Was it bad? Performance, of course. Is the patient dead or alive? Was the leadership okay? Was the communication okay? Did the anesthetist understand why he was there and what he had to do? Then knowledge, of course, we experience, but also case reports and also complication meetings are very important to increase our knowledge. I think at the end of a complication, you can say it was a good or was a bad complication, not only from the outcome, but was there the team? Did we do most of the things right to get him out? There are always different ways to roam, but most of the ways did we good job, even though we didn't save the patient. But I think you feel it right away. And again, have new ideas, and the most crazy good ideas maybe came out of complications. Also, maybe the night after. So what would you do afterwards? So if I may conclude this very theoretic part, afterwards, Azim, you tell me if there is still some time for one case example. Be aware, nightmares, complications occur. Be prepared because they occur when least you expect them. Prepare the team, so make a team, but also prepare the team to solve the nightmares. So the team is ready, all the material is there and has been ordered. And then learn from yours and other nightmares. And again, giving also tribute to patients who died or suffered, so that it will not happen to another patient. Again, we have to learn from our mistakes and make it more safe for the patient that to come. And of course, here the Monterhart Grand Rounds are definitely very important to learn and to do better our job in future. Azim, do I have time for, I think, 7 minutes case?
Of course, we have lots of time.
Okay.
We have lots of time.
So, did we become an A team? That's a question here, and let's see. This was 2013, so a little time ago. Okay, there was a complication, embolization of a valve here, lousy CT scan, measurements, lousy the same. It wasn't the standard, but sometimes we had this, radiologists still didn't know how to do gated CT scans, or also machines weren't at its best. So we tried, not so sure, okay, the 23 millimeter balloon didn't move, so okay, probably 26 is fine. We did maybe 2 cc's less because of the 23 balloon. Okay, looked nice. And what happened? Oops, okay, the wire, the valve embolized because it was too small. And well, of course, we couldn't get it out of the ventricle. We tried it, but it wasn't possible because of the stenosis. Fortunately, this patient could go into OR and did a good surgical job and was discharged 12 days later. I tell this because complications not only come in clusters, but they also come because one complication really a little bit may impact your behavior for the days or weeks to follow. Because not more than 3 weeks later, Old lady, Euroscore 20, okay, completely refused by the surgeon. Aortic stenosis. Here the CT seems a little bit better. Measurements we'll see lousy. 2013, we weren't yet so aware what this chunk of calcium here means. Now we are much more aware. But that was when we still learned, or I actually still learn. And we did our measurements. Here you can see we decided for a predilatation. Then we decided for the 26 millimeter Edwards, a little less contrast, but probably we were a little on the high side. And what you can see here after positioning, immediately massage was necessary due to the shock of the patient. What I like to show here, these are kind of covered gloves with a little bit of lead, which if you have to do a lot of massage, some of this gloves is nice to have. Unfortunately, you have to have one pair for every person who is massaging. Anyhow, what you can see here, pericardiosynthesis also has already been done. And here during the semi-selective coronary injection, because of course you have to see why it was tamponade was pretty clear, but you can see here this annulus rupture. So we found the leakage. So now what to do with this leakage? 2013, so quite a long time ago. A second valve, okay, would take time. We didn't know anything. Patient really unstable and really no candidate for surgery. And again, it wasn't me, which was the first operator, but it was Dr. Sakar, my second. Said, let's put some coils. So we had some experience with coils. So here with an Amplatz catheter, we throw in a lot of coils, and actually the bleeding stopped quite well. We drained and partially reinfused 1 liter, so it was really big bleeding. But the bleeding stopped, so it was quite effective. In this case, we positioned a little bit the catheter in the pericardium, but we were able to transfer to CCU our patient. Of course, in the aftermath, it was clear what happened. This is absolute contraindication to do a balloon expandable valve. But at the time, well, I didn't know, so I did my personal error. Here, a self-expanding valve probably would have done better, or we should have chosen a smaller valve, but I think balloon expandable valve here isn't a good choice. Also redoing the measuring, we measured too big, it was actually a little bit smaller, but all the aftermath. Here the outcome, okay, 27 days in coronary care. You can see here all the hemithorax here was full with blood. So not only the pericardium, because it was so high, also all the mediastinum and all the lung floated. Quite obese patient, as you can see here. You can see here nicely the coils and the valve. Actually, she got a little bit better after a week. But then she restarted to bleed. We redrained her, also the thorax, but at the end the patient died after 27 years. The patient was conscious actually during this time. She was extubated. We were able to communicate with her and also with the family. So this nearly 1 month gave us at least some time. So what we have learned, of course, here CT is important. We have to look well at them. Previous mistakes, of course, you think you learn about, but not always teach well. So sometimes. But I think what we've done here, the team approach definitely worked well, because to get this patient out of the mischief, out of the complication, what was a big achievement. Okay, she didn't survive at the end, but she came out of the cath lab. So I think here we really had an A team. Of course, the people with the massage. Maybe I was the one who was giving the orders. Fantasia from Italia, of course. The idea with the coils. intubation anesthetist, communicator. I think here it was a good team there, and we learned from it, and maybe we teached also with this communication, with this complication, which we presented in some meetings, something for other operators to treat their patients better. So I think here I may stop to share the slides, and we have time to discuss, Azim.
Excellent, Bernard. Thank you so much. That was exactly what we were hoping for, because way too often we just talk about the complication and the covered stent, the coil, but actually talking more about how we work as a team better and how to create that team spirit is super important. The only thing I take objection to is being called a dictator, but we'll get into that later.
In private.
I owe you for that, let me just say. Excellent. But Juan's with me. Juan, you had a couple of comments as you were watching about what causes complications, and sometimes we take on very high-risk procedures.
Yeah, no, Bernard, was a phenomenal talk. I really enjoyed it, and I mean, your approach was phenomenal. One of the things that I was talking to Azim while you were talking is that at the educational level we teach people how to use devices, right? But we don't spend enough time talking about decision-making process, and this is actually very similar to your analogy to the aviation industry. I was telling Azim that I learned from a good friend that also the military train people to deal with complex situations and have algorithms of decision making. And I really think in the future we need to create training environments that actually help people to learn not only how to put a coil, how to occlude an artery, how to react quickly to an emergency, but also how to make a decision during that stressful time according to the situation. Because I think as important as it is to teach people how to put an impella in and how to really, work on a groin that is bleeding, I really think the decision-making process and the steps that need to be taken is extremely important and not really discussed in all the big meetings we have. So
yes,
it's a phenomenal talk, very relevant and enjoyable.
So Bernard, you showed some cases when you were in Milano, and now you're at Humanitas. So, I mean, what do you do in your own center now to kind of encourage this team? Because you now had a new team, right, that you had to work with, new cath lab nurses, new techs, new fellows. How do you recreate that other than on the day of the complication? Because I think some of that work, like you mentioned, can't only be on the day of the complication. It's done every single day, right? So that on the day of the complication, you already have your team thinking and built and following you and working together. So any tips of how you did that on a daily basis?
Yes, I think first, but maybe this is also a little bit my character. You cannot go in a new cath lab and say from tomorrow on we are a team. This is impossible. It takes time. Maybe here it took me, I don't know whether it took me more time or it's 5 years now, and now I think I'm back to a dream team here. So I really enjoy it. But 5 years it's a long time. And so I did the Milano team. It was probably the same time, and now this, and now I really enjoy here in this. What you can do to prepare the team, of course. I didn't find a bad cath lab because Presbítero prepared them. Nurses are really excellent. They were used. Okay, something I didn't like, I wouldn't have done different. Something I was able to change. Something I wasn't able to change. I didn't bring my people with me, which maybe is also a little mistake. So maybe sometimes it's good to, if you want to have success quicker, it's better you go there in 3 people then you know. I went alone, but still, you can build it up. And then, of course, now with Antonio Colombo, Damiano, Antonio Mangieri, you know them. These are your fellows. And they gave me the hints to the dictator because they told me how you treated them. I treat them much better, they say. I don't know whether that's true. Anyhow, a little bit to observe. When I came here, I think the worst thing that I saw in my career, there was a complication, and one of the colleagues showed from outside, he's not working here anymore, from outside, interesting, but he wasn't in the complication. He didn't offer his help. So no, it was not, maybe he didn't trust himself to go in, but he didn't either offer his help. And this was something I really got mad about it. And it's one of the few times I really, I think, raised my voice. No, complication here. Everybody has to get involved. It's not a thing of one of the members. It's a thing of everybody. And then again, okay, it takes some time, but now, I do less PCI, and maybe I look a little bit more after the individuals, after the team. I enjoy it. Now I inflated maybe enough balloons for my age. So I can do also something else. And then working in a team, and you go on holidays, you can trust on it, you rely on it, or they make complex cases and they do it probably better than you. And then something maybe you don't like, but you can discuss it. And we discuss it really. So if there was a mistake, I don't throw them out of the cath lab. Next time we try to do it better. So with patients, and I like to have a positive work environment. I depend on it. I want to go there, have a smile on my face. I want to go out there, have a smile on my face.
Yeah, no, I definitely agree. I mean, one of the things I've done here, which is kind of, I think wherever you go, you take things with you and you learn things. Some are better than what you were used to. Some you bring the things from the past. So, one of the things that I've really liked here in the US that we didn't do in Milano when I was there was we always have a timeout at the beginning of the procedure here. I think you have it in Humanitas too, but at San Raffaele, we never had it, right? And so sometimes the timeout will be very long even, because we know we're going to do a super complex case, a very high risk case, where there's a chance the patient's going to end on ECMO. We know there's 3 or 4 potential complications. In that timeout at the beginning, we sit down, we make sure all the team understands if this complication happens, which there's a high risk, this is going to be our algorithm. There's all the material. We go through all the potential complications and we get everything ready as if it's going to happen. And the whole team kind of understands before starting what the potential complication is going to be. Because some of them, you can predict a little bit. You try and mitigate, but you're going to do a patient with very complex access and you're going to try and dilate it up. You're taking a risk of a perforation, right? So you need to know that the team needs to know, okay, the first step is going to be aortic occlusion balloon. Then we're going to try and go with a covered stent. Then we're going to do this. So that's the one thing we do, which I really like.
When do you do it? When you're already at the table, dressed, or you do it before you sit together?
Usually we'll do it before we sit together, okay? And then we always do a timeout as well, where, the timeout, and in the timeout, if maybe the anesthesiologist says something that we didn't think about, okay, or someone else says something, we'll stop again and rethink about all our strategies, okay? So we'll sit down before everybody goes into the room. But the other thing that I found really useful was, because like you said, during a complication, it gets very heated. Everybody's very busy. Everybody's rushing and concentrating on the patient. Sometimes things don't go so smoothly. Sometimes voices are raised by different members of the team. So what we make it a rule is that after the complication's done, patient's stable, whatever the result is, we've done our best, and the patient's out of the room, we come together again and we do a debrief, all right? And we go through what worked well, what we did correctly, and how we worked well as a team, and what didn't work well. We couldn't find the 8x40 covered stent. There was only a 10. What happened? Why wasn't it there? Right? So we go through all of that so that hopefully the next time those learning points are embedded in the team.
Yes, that's also for me from Mirano or maybe San Raffaele, where all these procedures weren't there, which sometimes we hate these procedures, of course, they're time consuming and so on. But I think this is definitely important, because you have to remember what is your really objective with this patient. No, this is 10 or 15% ejection fraction. There is a small marginal branch, but there's also long lesion on the LAD, and you lose your time with the marginal branch, and then there's an arrest, and you didn't start to do the LAD. And if you would have done a timeout, probably we do it when we're still already dressed, and we are here. This is Mr. XY, and we want to do PCI, and our first objective is this. I think could have saved the patient if we would have done it better in this case. So I think there's a lot of things to learn from other countries, as you said, from aviation, and so yes, we are here to learn. We still can improve.
Absolutely. So there's just maybe one last question before we let you go. There's a question from I think probably our interventional fellows, who said, any particular advice for fellows as they're going from, that year, your first year when you're a consultant or attending after your fellowship is probably one of your hardest years, I think, right? So they say, any advice for them as they transition to becoming an attending consultant? How can they make their training during your interventional year, during your fellowship, more useful in this regard? Any advice?
Well, I think if you are there during a complication, get involved somehow. So, of course, if you are doing this interventional year, you have to put lead on. You have to be ready. And you start to do massage. So you offer your help. Okay, the others are tired, and massage, everybody needs to know. So you start with massage. Then if I see the fellow there dressed and who doesn't take 10 minutes to get his gloves and his gown on, come here and keeps the groin. So right. The more you get involved, actively involved, the better. And then look at the complication and ask, okay, if you do the debriefing, you're there, good. But if not, ask. And then there are so many methods to learn, to study afterwards, what to do. I think try to be there, because we are, well, luckily or unluckily, we have enough complications of small or big in the cath lab where you can learn.
Yeah, I agree. I think be at every complication you can be, see every complication you can see. I mean, the more you can be at and see of other people's complications, the more you learn to be able to help in your own one.
Look, I mean, I train. I remember when I was training, one of the best operators I trained with was Al Reisner. He was a father of brachytherapy, and I will never forget, what he told me is that is not about pushing wires or balloons. It is about predicting risk, and more importantly, to know who is the patient that is going to get a complication. So one of the things that I would, advise people going into a new job is spend some time doing risk stratification and understanding what is the case that is beyond their capabilities, and ask a senior operator to work with them during those cases so they get more skills, so they don't induce complications that should not really be there. And the second thing is actually tell senior operators to call them once they get a complication so they learn how to deal with it. Because I don't really think that, in 1 year, even in 2 years, people get enough experience in how to deal with all the spectrum of complications. So it is a learning process. And I really think that actually tagging along with somebody that has dealt with a lot of complications in the past as a second operator is the best way to learn those skills.
Yeah. I take to heart something you said earlier on, because it's something Antonio he never said it, but he taught me. And you said, all complications can be broken down to human error. I mean, you may not agree with this. And the one thing I would say to the fellows is, when you have a complication, don't blame the device, don't blame the patient, start with trying to figure out what it is you did or could have done differently that would have prevented it, right? And sometimes you may, at the end of that analysis, figure out there was nothing you could have done differently. The complication just would have happened. But if you can sit there and be self-critical and really think, look at the procedure over again, show it to other people, try and analyze it over and over again to really understand what could you have done differently to prevent it. To me, that was probably one of the best things I learned from Antonio. When we had a complication together, he would not sleep for days. I mean, he would call me at 11 o'clock in the evening. He said, I think I figured out where I messed up or where I screwed up. We shouldn't have done this. And then the next morning, call me, well, okay, maybe that was okay, but we shouldn't have done this. And for days, we'll sit, we'll analyze it, we'll make sure that we take away from that complication something that we learned so that we can use in the next patients, and maybe sometimes there's nothing, okay, but at least you sit there, you analyze, you be self-critical, and you figure out how you can mitigate it in the future. I think for me, that was one of the biggest pieces of advice I can give to the young fellows.
And you can imagine how lucky I am now here to work with Antonio. So he comes in for the complication. Of course, he has the best ideas always.
Absolutely.
And if we talk about cases, old cases, so we talk much less about the Osolemio case than about the 3 complications we still have here, and they are 95, 96, 97. So
no, absolutely.
If you don't forget them, this is good, because you paid tribute. You paid tribute. You did a mistake, and we are lucky. We are not pilots. We wouldn't be here anymore. So we can work accordingly.
I agree. Don't forget your mistakes. Use them to be better and to continue to learn. I think you're right. It's the best justice we do to our patients, and the best ways we can remember them. Bernard, thank you so much.
Thank
grazie
you.
mille.
Take care.
Enjoy your vacation.
Take care.
We miss you. Hope to see you soon. Okay.
Right, bye.
Thank you so
Okay.
much.
Bye-bye.